Educational Hub sessions, and we've got a real treat today. We're joined by Dr. Gozie Offiah, who probably needs little introduction. As most of you know, Gozie is a senior lecturer here at RCSI and the National Clinical Lead for Intern Training with the HSE. And Gozie, today your title, it's basically the highlights from your PhD, which you've recently defended, and a massive congratulations on that. I'm sure you're delighted to have a little bit of a line drawn onto that now. And we're really looking forward to hearing about that today.
Brilliant. Thank you very much, Jenny, and thank you very much, everyone. I'm going to just share my screen and hope that we will see the slides. There we go. Can you see my screen?
Yep, that's come up lovely.
Yeah, you can see the slides, yeah?
Mm-hmm.
Perfect, that's great. Thank you so much for the opportunity. I'm delighted to present my PhD study, as you said, just recently defended, so it's still all fresh in the mind. So the topic is on gender in surgery and is understanding female surgeons' lived experiences in the surgical education. In the next 45 minutes to an hour, I will provide a background to the study, my study, the methodology I used, the methods and the data analysis used. And I'll discuss all of these in details, obviously, for those doing PhD and MD studies within RCSI. I'll also provide an overview of the theoretical frameworks that underpin my study, followed by the key findings, how my findings will impact surgical education, policy and practice, and the originality of my study, and finish up with further research. As a background to the study, the evidence of female surgeons dates back to 3500 BCE in Mesopotamia. Even then, there were challenges for women practicing surgery. The literature on gender and surgery in the last few decades mostly highlighted the surgical ethos involving characteristics traditionally ascribed to men. So things like courage, arrogance, aggressiveness, and of course, men's club that exclude women, as noted by Joan Cassell, who's published a lot on this topic. Other studies have since followed on gender bias and gender discrimination. This has led to several discourses within the area of medical education and gender studies on how best to navigate the surgical world, as noted by studies published by Hill et al. In the middle of the screen. Further work in the literature has moved the discourse to why gender is important in the surgical workforce. A recent study by Meredith Expolius focused on the relationship between country income, the Global Gender Gap Index, gender equity, and female surgeons' experiences. So the literature identified that gender imbalance exists worldwide in surgery. And surgical workforce diversity is important for patient care to ensure that the surgeons represent the patients they serve. The workforce challenges in the NHS, for example, now present greater challenges than funding challenges. So while loads of research in the literature have highlighted barriers for women in surgery, my study focused on the perception of female surgeons, colleagues and patients of female surgeons on the topic of women in surgery. I used different methodologies and theoretical frameworks to make sense of their lived experiences. And to that note, I identified 3 research questions for my study. How do dimensions of culture interrelate with gendered surgical cultures? What gendered transitions are experienced by surgeons? And how do surgeons' multiple identities intersect? And what influences do those intersections have on surgical lives? To answer these research questions, I used a qualitative research approach to provide a comprehensive picture of the underlying issues for female surgeons. Outlined on the slide is the methodological approaches that I used. I now discuss these in detail, showing how I connected all the different aspects. The alignment between the ontology, which is the nature of reality, the epistemology, the study of knowledge, the methodology and methods demonstrate internal coherence, an element of research quality. As I said, ontology is this nature of reality. It spans from realism to relativism, and relativism believes that knowledge is dependent on culture, society, and historical context. My study aligned with a relativist ontology, which is best understood through constructing, interpreting, and making sense of the socially constructed world. The socially constructed nature of reality provides a deep and sophisticated understanding of people's experiences. It follows that the philosophical stance underpinning my qualitative research is social constructionism with an interpretive approach. The interpretive paradigm is concerned with understanding the world as it is from the subjective experiences of individuals. This naturally leads to narrative inquiry, which explores the lives of individuals and the stories that they tell of their lives. Narrative inquiry is gaining popularity within the context of medical education. As well as the internal coherence, another measure of quality within the qualitative research is the concept of reflexivity. Reflexivity is an essential part of interpretive research, and it means understanding the researcher's position. So for me, it was about emphasizing my presence within the research. I needed to highlight it to get an insight into the perception of others. I engage in self-reflexivity as a Black female surgeon working in Ireland. I was an insider research in the world of women in surgery, but I also engage in team reflexibility for a rigorous analysis process. Throughout my PhD, I occupied several roles, and I had to creatively combine all of these roles. The diagram on the right there shows all the different roles that I did occupy throughout my PhD. I paid special attention to gender and ethnicity, which focuses on shared cultures, language, ancestry, beliefs, and practices. I recruited in Ireland and Scotland, as I am embedded in both environments, working in Dublin, and my PhD was in Dundee in Scotland. I used maximum variation sampling with emails, posters, snowballing, and this allowed me to recruit individuals experienced with the phenomenon of interest as female surgeons were in this study. I had a diverse sample across 6 Irish hospital groups and 7 Scottish health boards. There were 14 surgical specialties. There were female surgeons of all grades, male and female colleagues from nurses, anaesthetists, physician associates, and male and female patients. All of this adding to the uniqueness of my study. I used biographical, narrative, interpretive interviewing for all participant groups, with the key question, for example, for female surgeons being, tell me the story of your life as a surgeon. Evidence from several studies have indicated that female surgeons are more likely to work in certain surgical specialties, so things like obs-and-gynae, pediatrics, plastics, while in contrast, male-dominated specialties include orthopedics, neurosurgery, and thoracic surgery. It was thus essential that the recruitment for my study included participants from a range of specialties to explore diversity across both male and female dominated surgical specialties. Ethical approval was received at East of Scotland Research Ethics Committee to cover all 14 health boards in Scotland. However, there is no umbrella ethics in Ireland, and thus the need for individual ethics in the 6 hospitals within 6 hospital groups in Ireland. I used framework analysis to identify thematic patterns across my data. The 5-step framework analysis is listed on the slides there. I participated in an inductive process, beginning with identifying key themes within a subset of data. I listened to audio files, I read all the transcripts, which led to an 18-page coding framework document. I then coded my entire data set using NVivo. On the screen is on the right-hand side, the left-hand side is a screen grab from NVivo. NVivo is a computer-assisted qualitative data analysis software that I used. It shows the charting phase from codes to sub-themes. I also used narrative analysis to capture the whole story. I was able to analyze participants' lived experiences and gain a deeper insight into what and how participants narrate their stories. I now discuss the theoretical framework I used. For my first research question, how do dimensions of culture interrelate with gendered surgical cultures? I used Hofstede's cultural dimensions theory as a framework to interpret my data. The 6 Hofstede's dimension offers several lenses through which culture can be examined and compared, because they reduce the complexities of culture into quantifiable dimensions. The 6 dimensions are listed on the diagram on the screen. For my second research question, what gendered transitions are experienced by surgeons, I used the multiple and multidimensional transitions theory defined by Jindal Snipe as an analytical framework. MMT theory suggests that people inhabit multiple domains with complexities attached to each domain. The analog of the Rubik cube is used to describe transitions as an ongoing process. A move in one direction affects another, as noted in the image. A change in policy leads to a change in social cohesion, which leads to a change in organizational culture, and so on. Finally, for my third research question, how do surgeons' multiple identities intersect, and what influences do those intersections have on surgical lives? I used intersectionality theory as defined by Crenshaw to make sense of my data. Intersectionality theory is a method of studying the relationship between personal and professional identities. This theory suggests that no one identity, for example, gender, is prioritized over another, for example, ethnicity. Intersectionality is integral to equality and diversity. The diagram notes 5 identities, but there are other identities not included in the visual. It is important to note that all 3 theories mentioned thus far are all underpinned by the epistemology of social constructionism, people constructing meaning as they interact with the world. There were 3 main themes that were identified from my data. I now discuss each of these themes: gendered surgical culture, gendered surgical career transitions, intersecting gendered identity of surgeons. The first theme, gendered surgical cultures. The diagram illustrates the interplay between Hofstede's theory of cultural dimensions and the surgical cultures based on my data. Cultural barriers to career progression manifested themselves in issues like competition, linked to Hofstede's masculinity and individualism dimensions, surgical hierarchies linked to Hofstede's power distance, long-standing gender traditions excluding women linked to Hofstede's uncertainty avoidance and long-term orientation, and the personal sacrifices during prolonged surgical training linked to Hofstede's restraint dimension. In the next few slides, I provide some exemplar quotes. Within Hofstede's dimension, masculinity represents preference for achievement, heroism, assertiveness, and competition. Participants narrated how it was essential to enact competitiveness to progress in surgery, and how this acted as a barrier to career progression. But male and female surgeons narrated the need to have an academic and educational advantage to be competitive for a surgical training position, as noted in this quote from a female Scottish trainee. I had publications and a higher degree. I had done an MD and I wasn't even shortlisted for an interview. And then I applied again in a year, and then applied again the next year. So it was very, very difficult. And the year I actually got in was the last year I decided to apply, because I was in my last year of my PhD. And I was at the point where it was so stressful that I said, okay, if I'm not successful, I'll become a staff grade. This female trainee identifies systemic competitiveness as a barrier to her career progression. She only got onto the training program the last year of her PhD, despite having an MD. Many participants narrated how one degree was sometimes not enough, and the need to have 2 or 3 extra degrees. Interestingly, these extra degrees were seen as an exception in other non-surgical specialties. Participants noted that the system also creates competition due to the limited number of training places, thereby creating a nasty environment for everyone, as they are all fighting for the same limited posts. Systemic competitiveness served as a barrier to collegiality and collaborative working. Power distance focuses on hierarchy, which preferences male in all societies. Within this dimension, colleagues identify specific challenges faced by female surgeons with regard to surgery's systemic inequalities and inherent biases. Participants noted that female surgeons had to work harder to be respected, and that power was unequally distributed between male and female surgeons through volume and expectation. In this quote from a female staff grade in Ireland, she narrated her challenges as a surgical trainee in a different country, and how the consultants decided her fate in surgical training. But in my 3rd year, which was my final year, I was on the pill. But then I had an appendicectomy. After the surgery, I discovered that I was actually pregnant on the pill. It was then that there was a board meeting again. They decided that we can only allow 1 pregnancy for 1 trainee during the whole training. And we've allowed this one pregnancy. So what do we do with her now? And they knew the whole circumstance, as the surgeon who had done my appendicectomy was one of the board members. And he knew what had happened, and he came to me and said, "We have decided that we will allow you to finish your training early if you give in your resignation. If you don't, we will not sign you off to sit the fellowship exam." So I was asked to resign because of my 2nd pregnancy. This is bullying. This is harassment. But my only fear was that if I didn't get my exam, that's what I'd struggled for gone. This is a powerful quote demonstrating power distance and the reluctance to challenge those in charge due to surgery's hierarchical culture. The quote also highlights how team members maintain loyalty and the power difference between surgical consultants and trainees, who are perceived to be at a different level of the clinical hierarchy. Participants also spoke about the consequences of raising concerns in the face of poor professionalism and the adverse impact on their careers. One female surgeon narrated how being assertive and speaking up is misinterpreted as being a troublemaker or neurotic. So female surgeons reported putting up with these in pursuit of their training. The restraint dimension stands for a society that suppresses gratification of needs. All participants, including patients, described the numerous sacrifices and delayed gratification to achieve the ultimate goal of being a fully trained consultant surgeon. I did my written exams 10 days before I had the baby. Well, I had to. I was studying during my pregnancy. I stopped working 3 weeks before he was born, so I had 2 weeks to study, and then I passed the written part. The oral is obviously more tricky. It was a time I was actually commuting in that faraway hospital 90 kilometers away, so I was coming back late and I had to study. My husband was a lot hands-on. That was a hard time for him. I passed my last exam. I didn't have to, but it was for recognition. It was for the European Board of Surgery. And I said to him, okay, well, look, I'm going to present for that exam. I need 6 weeks where you have to forget about me. So I was working, coming back home at 6 o'clock, studying from 6 to 1, going back to work the following day and studying 12 hours during the weekend. He took over, but that's my husband. It's a big commitment for him too. This quote from an Irish female consultant encapsulates the sacrifices she made for recognition to a European board. She sacrifices her personal and family life and talks about hard work and commitment for reward and recognition. Participants also narrated the obstacles to enjoying life due to long working hours, prolonged training, and multiple exams. In relation to the key findings under this theme, analyzed using Hofstede's theory, gendered surgical cultures transcend other dimensions of culture. Based on Hofstede's cultural dimension theory, competition, achievement, and heroism associated with masculinity are pervasive within surgical cultures. Female surgeons demonstrated a willingness to overcome gender, societal, and cultural barriers to progress their careers. Surgical cultures are committed to maintaining the gendered status quo, with long-standing traditions as noted by Hofstede's uncertainty avoidance and long-term orientation. The second theme is gendered surgical career transitions. I used MMT theory to explore the transitions in surgery. The diagram you see illustrates the several transitions within surgical careers. It's clear from the diagram that these transitions are non-linear with impact on others as depicted by the children in the image. In the next few slides, I provide some exemplar quotes. All participants describe transition as a surgical trainee as the most challenging within the surgical career trajectory, with personal and interpersonal impacts on them. Gendered work transitions identified multiple types of transitions. Returning to work post-maternity leave was considered challenging for many female surgeons, considering the requirement to maintain surgical competence despite being out of work for 6 or 12 months. I have to say, yeah, coming back after maternity leave, I can remember holding the retractors thinking, what am I doing here? Really having very little to talk to with other people and feeling like an absolute fish out of water. You know, moving from childcare 24 hours a day to holding retractors, I just felt like a fish out of water. It's a very difficult time. I think that transition, coming back in after being out for a year with family, I imagine that a lot of female doctors will be lost in that transition. This Irish female surgeon, a staff grade, narrates her challenges transitioning between motherhood and her professional life as a surgeon. She uses metaphorical talk, fish out of water, and emotional talk, very difficult time, to describe the struggles to reintegrate post-maternity leave and the emotional impact of the transitions. Other female surgeons also reported the new mother surgeon transition as difficult, impacting other aspects of their lives and their families. All participants in my study acknowledge that doctors make multiple geographic transitions throughout their careers as part of training. Some of these geographical transitions included moving to a new hospital or new clinical team, or moving from one level of seniority to another, from intern to SHO to registrar, or moving abroad for research or fellowship to progress your career. These transitions are multiple and multidimensional in nature, and they impact families, creating transitions for loved ones too. But this was really, really hard. I used to get in the car on a Sunday evening to driving down the motorway. I'll have tears in my eyes. There's a knock on because it puts tremendous stress on my wife with all the health problems that come with tremendous stress. This quote from a Scottish male surgeon reports his experience as a surgical trainee of weekly transitions between home and work and the associated impact on him and his wife. Jindal described educational transitions as a transfer or moving on in an educational context. Educational and geographical transitions are linked in my data and triggered transition for family members, as noted by the Scottish female surgeon. So there have been a lot of sacrifices for my husband and my children. I had to move my oldest daughter at least once out of school. Having gone through the registrar training, they have been quite settled here. And then last year, I did a fellowship in Australia. So everybody moved again with me. And it has impacted them. I'm surprised the older one has changed into high school, has made the jump really well. Whereas the younger one is really struggling and needs a lot of support as she's missed half a year. So she's kind of needing extra support. And of course, loads of frustration, lots of mental support. This female surgeon narrates the geographic transition from one country to another due to her educational need, necessitating her family to move with her. The female surgeon's children also experience educational transitions. She reports how her children had to move school with the consequent physical and psychological impact on them. The key findings from this theme identify a huge range of gendered transitions. Gendered work transitions included maternity leave, part-time training, leadership, and transitioning out of surgery. The conceptualization of these transitions using MMT theory showed that female surgeons experience transitions at different stages of training with impacts on their personal, interpersonal, and work life, demonstrating the complexity and multidimensional nature of transitions. The third and final theme from my thesis is intersecting gendered identity of surgeons. I use intersectionality theory, as described earlier, to explore these intersecting identities. The diagram on the slide illustrates the novel findings from my study showing the intersecting identities between gender and ethnicity, age, parenthood, professional identities. In the next few slides, I provide some exemplar quotes. As mentioned earlier, ethnicity focuses on shared cultures. Very few studies have examined how ethnicity and gender intersect or combine to affect surgeons' career, and is another novel finding from my study. Crenshaw coined the term intersectionality to describe bias and violence against Black women. Intersectionality postulates that ethnicity and gender are not separate, but mutually define and reinforce one another. It was clear from my data that the surgical trainees of colour that were non-Irish in Ireland and non-British in Scotland seemed to have a more challenging time in the workplace beyond simply being female, as described by the Scottish female trainee. I think nationality for me and for other people does bear out in the NHS. I currently work in a pretty female-heavy environment. Shall we say, in terms of trainees, some of us are white and British and some of us are not. And the trainees that are non-white and non-British definitely get a harder time, added on to the fact that they're also female. So that's quite difficult to witness, getting very different responses to the same kind of training environment. And so yes, I don't think that being female is the only potential issue or source of bias in surgical training. This quote highlights the intersections between gender and ethnicity. The female trainee described how people of color are treated differently. She explicitly states the added challenge in being female as well, indicating how intersecting identities can lead to further inequalities in training experiences. Female surgeons of color in my study also reported being discriminated against because of being a person of color. This is noted in challenges experienced by non-nationals in getting a job, being offered service posts rather than training posts. Another intersecting identity is that of parenthood, gender and motherhood, but also gender and fatherhood. Historically, there's a perception that motherhood was unacceptable in surgery, as the structure of surgical training discouraged women interested in both surgery and motherhood. This perception had negative impact on female surgeons and positions they could occupy. However, I focus on fatherhood here as a novel finding in my study. I've got no problems with a year of maternity leave, absolutely none at all. It should be mandatory, and it should be mandatory for all men as well. If I have a newborn child, I should be offered a year off as well. It should be total equality. You hear of old chauvinists in the past going on about, oh, the women shouldn't get time off to look after their kids. That was the reason why women wouldn't go into surgery. It's absolutely ridiculous. But everyone should be equal. There was a lot of time that my wife would have appreciated me at home, being home all day on maternity leave with 2 young children, with a husband who's never there because he's working every hour under the sun. It's not good. This Scottish male surgeon expressed the need for an equal system supporting parental leave for female and male surgeons. He showed genuine interest in parental leave to help embrace his fatherhood identity, as well as helping support his wife to look after 2 young children. This male surgeon illustrates how he felt discriminated against for being a father in surgery, highlighting the problems associated with intersecting father and surgeon identities. Other male surgeons in my study also described their desire to achieve work-life balance to allow them time for parenting. In my data, age identity intersected with gender, but also with masculinity described earlier. Present in my data was the sense that older male surgeons were more experienced and competent, as noted in this quote by an Irish female patient. I think he's more experienced. He understood it a little bit more because he was more mature. I find the younger doctors don't have a whole lot of, male doctors don't have a whole lot of patience. Maybe that's because I'm getting older, I don't know. Seniority brings competence. It kind of made you feel comfortable because you know what he's talking about, and he gives you the impression he's good. I mean, you know by looking at him, he's good at what he does because he's got the confidence and age on his side. And you go, well, he's been here for a while, so he's obviously very good. This patient described how she felt comfortable because the surgeon was older. She equates his maturity and seniority with competence. She contrasted the younger male surgeons with a lack of patience rather than competence, indicating the interplay between age and surgical skills. Several female surgeons also reported patients querying young female surgeons' competence, asking, are you sure you know what you're doing? Is there going to be someone with you in surgery? Are you being supervised? The key findings from this theme, based on intersectionality theory, indicate that female surgeons demonstrate unique experiences of intersecting identity, as do male surgeons. Age identities were perceived to interplay with surgical skills and competence. and the competence of female surgeons were questioned, with female surgeons of colour more affected due to their intersecting gender and ethnic identities. Having provided the key findings from each theme, I now present the impact on surgical education, policy and practice. Under the theme of gendered surgical cultures, at the individual level, it is essential to raise awareness of surgical cultures that exclude women by empowering them to raise concerns when they experience challenges. It is also essential to raise awareness of gender and surgery to male surgeons via formal training, encouraging bystander intervention in the face of discrimination or harassment. At the organizational level, there's a need for more flexibility through and across training programs. The availability of mentors and role models for female trainees should be actively incorporated into surgical training programs. Lastly, an awareness among all staff of equality and diversity issues through organizational policies and training to facilitate the integration of international medical graduates and doctors in Ireland and Scotland is very essential. Under the theme of gendered surgical career transitions, at the individual level, there's a need to enhance medical students and trainees' understanding of the different types of transitions associated with surgical training. This will better prepare them for the complexity and the multidimensional nature of transitions. At the organizational level, leadership programs is essential for female surgeons to foster growth and to help address transitions to senior roles and the gendered experiences for female surgeons within those leadership roles. Training programs should be designed with family-friendly structures and processes to help female and male surgical trainees to accommodate family life. For example, reducing the number of geographical transitions during training, allowing trainees to lay down roots of family life. Under the theme of intersecting gendered identities, at the individual level, gender awareness training through formal curricula is essential. Organizational policies on parenthood identities is essential for a better and fairer work environment. Finally, there's a need to raise awareness of diversity and inclusion within our multicultural society via campaigns on respecting and valuing the diversity of all staff, including female surgeons, male nurses, people of color, and internationally qualified healthcare professionals. An effective workforce caters for gender diversity, but also diversity of other identities. In the last 45 minutes or so, I've brought you through my PhD journey. It is worth mentioning the challenges of a part-time PhD on a very topical issue. Over the last 6 years, there's been loads of publication on gender in surgery. As a student, this meant always trying to find the novelty within my PhD study. I'm glad that I maintained originality in my study and have significantly contributed new knowledge to the literature on the topic of women in surgery. I have focused my thesis and this presentation on the original elements rather than those that replicate other research. I demonstrate these novel aspects under 4 headings. Participants. This is the first study to explore the perception of colleagues and patients on women in surgery. Added to that is the diversity across surgical specialties and colleague specialties. The use of narrative inquiry and biographical narrative interpretive interviewing across 2 different healthcare systems and the conceptualization of the data using multiple theoretical frameworks are all novel and add to the existing literature. My PhD findings have been disseminated both at national and international conferences over the past few years, with several publications on the way, hopefully. As a part-time PhD student, it was hard to juggle work and maintain the momentum of the PhD. My advice to all MD and PhD students is to find or agree protected time, otherwise the study struggles. It is important to attend conferences, not just to disseminate your findings, but also to see what's up and coming and how it relates to your research study. Finally, I think a good researcher must be open-minded to the idea of building on their research. And hence, this is how I believe my research can be built on. Firstly, I think further research on culturally diverse countries, considering the interrelationship of surgical cultures and Hofstede's dimensions. A different cohort of doctors from other countries, in contrast to Ireland and Scotland, would lead to a better understanding of the surgical culture as a whole. Longitudinal qualitative research to delve into the transitions of a doctor from medical school to surgical training and to consultancy will provide richer data on these transitions and their impact. In-depth qualitative research into the intersecting identities of male surgeons and how they differ from female surgeons' intersecting identity will add to the existing literature. And secondary in-depth narrative analysis on the use of metaphors, language, laughter, pronouns, and hesitation is needed. Special thanks to RCSI and colleagues within RCSI who supported and mentored me throughout this process. NDTP was very kind to give me protected time, so I'm grateful to them as well. I had 3 amazing supervisors who were so knowledgeable on the topic and really very supportive and got me through provided and completing this PhD in the middle of a pandemic, and I'm really indebted to them. Owen Kelleher drew the pictures and he really did bring the results, my results, to life with his images, and I'm grateful to him. But special thanks really to the female surgeons, the colleagues and patients who were so generous with their time and openly shared their experiences with me. I think I have to finish up by saying thank you to my family, my husband and my 2 gorgeous girls who weathered this storm for me. It wasn't an easy storm, but I think having them on my side was very supportive and really helped me. Thank you very much for listening. I'm very happy to take any questions on the presentation.
Well, Gozie, that was absolutely fantastic. And all I can